so we plateau in it. All right, everyone. I think that we kind of got everyone into this meeting. Welcome back. I'm Melissa Wilson. I'm a physician assistant at the University of Pittsburgh, and I'm the host of From the Clinic to the Living Room. I'm really excited to have this topic back. Tonight, we're going to be talking a little bit about ctDNA, which is circulating tumor DNA. We're going to learn all about it from A to Z, what it is, how it's used, and then we're going to leave a couple minutes at the end of this webinar to ask some questions. I have a very special guest with me tonight. This is Dr. Zainab Erlou. She's a medical oncologist at Moffitt Cancer Center, and she is the associate professor at the University of South Florida Morsani College of Medicine. I'm very, very excited to have the opportunity to speak with you. I've been watching a lot of your videos, and you're such an excellent speaker and such a great teacher. So welcome to my very informal webinar.
Thanks so much, Melissa. Really appreciate the invitation.
So I guess just to kind of get started and just sort of set the stage, if you wanted to go ahead and explain, what is ctDNA?
Yeah, so we know that cells in our body, including tumor cells, will shed cell-free DNA into our circulation, right, into our blood. And in patients with cancer, tumor cells can also shed this cell-free DNA, right, which is what we call circulating tumor DNA, or ctDNA for short. So essentially, when cancer cells are breaking down, they can actually release DNA fragments, right, into the bloodstream of the patient. So the ctDNA can be released into blood via, dying of cancer cells when they're breaking apart, or can be directly secreted from the cancer cells.
So I guess one of the questions that I often get in the clinic about that is, are these active cells that are floating around in my bloodstream, or are they just sort of dead fragments that, can't or aren't spreading? I guess that I know that's a really difficult sort of question, but patients will always say, well, if I have ctDNA in my bloodstream, does that mean there are cancer cells in there?
That's a good question. So I think it can be from both, right? As cancer cells are dying, right? Apoptosis, necrosis, right? They can shed these DNA fragments into the blood, but active growing cancer cells can spread it as well. So I think that's why we tend to see, right, both in melanoma and other solid tumors, detectable circulating tumor DNA, typically in patients who do have active cancer.
So you have this circulating tumor DNA. How exactly do we first collect this, and then how do we measure it?
Yeah, so the first part is that's kind of across the board for, I'd say, most of the ctDNA assays that are currently used and available is a blood sample. Depending on the assay, that may be 1, 2, sometimes up to 3 tubes of blood that may be collected in a couple 10 ml tubes. And then that blood sample will be spun down in the lab to just the plasma components, right? So that's kind of the liquid part of the blood that's removing the blood cells from it. From there, right, then we're able to, with further techniques, isolate the cell-free DNA, right? So it could be something like 20 to 50 nanograms, like 4 ml of plasma in a 10 ml tube. And then the pathologists, right, are then able to analyze the samples. But there'll be differences then on the next steps on, and we can get into it further if you like, on how that analysis may be done, because there's some differences between whether you're using a tumor-informed circulating tumor DNA assay or a tumor-naive assay.
So I would like you, if you don't mind, to clarify between those. I know the one that we use at our institution does have a tumor-informed assay where we're actually using archival tissue to make a probe. So if you wouldn't mind to elaborate a little bit on that, that I think would help our listeners.
Yeah, absolutely. So I would say, to take a step back, one of the initial I would say, methods for looking at circulating tumor DNA was what's called this digital droplet PCR method that essentially looks at a single tumor mutation in plasma samples, right? So that's a tumor naive approach. You know it, you don't have to do additional sequencing of tumor tissue, and then you can follow one mutation like BRAF-600E and RAS Q61K, right? Very specific. And then you can follow that serially in blood, right? But of course, if you're only following one tumor mutation, right, can that, be less sensitive than some of the newer methods? So I would say more recently, some of the data that's come out is ctDNA assays that are using this, what we call next generation sequencing, right, where we're looking at multiple tumor mutations, right? And then to break that down further, with tumor-informed next generation sequencing assays, you actually need the tumor sample, right, to then be able to do sequencing to figure out which are the tumor mutations of interest, right, that you're then going to test in the plasma sample. So essentially, with these tumor-informed assays, there's actually a custom or personalized mutations of interest, right, that are found in that patient's tumor. And there's a custom assay created for them that then in all the plasma samples that are collected, right, there's testing done to look for ctDNA of all those mutations. And then depending on the specific test, that could be anywhere from 16 mutations, what we call single nucleotide variants, could be 50, 250, right? So the advantage with the tumor-informed ctDNA assays is typically compared to tumor naive, they tend to be more sensitive and they have this
Yeah,
lower limit of detection. The disadvantage is they require tumor tissue, right? So
sure.
you do have to have enough tumor sample. It's not a lot, but there has to be, it could be from the dermatologist biopsy of the original melanoma sample, like a punch biopsy, could be, metastatic setting, imaging guided biopsy, etc. But there does have to be an available tumor sample. It could be archival that's available to send to, right, to be able to do this analysis, because you have to figure out the mutations of interest from there and then run them in, test for them in your blood samples. The tumor naive assays, the advantage there, they don't require tumor tissue. So they essentially have a predetermined kind of panel of this actionable mutations of interest, right? So melanoma, for example, you can imagine, BRAF, NRAS, right? Some of these more common mutations, right? So they have these determined mutations of interest that then just requires the blood sample, and then that sample is analyzed to look for small amounts of those mutations there. The advantage, not needing tumor tissue, and interestingly, you could possibly use these types of assays maybe for screening or early detection of cancer, right? Where you don't, right, where you're trying to figure out, does the person have cancer? So there could be some really interesting applications for tumor naive ctDNA assays, but the disadvantage is typically they tend to be less sensitive than the tumor informed ctDNA assays.
And that makes sense. You're using someone's actual DNA to follow versus not. But it's nice for our patients to know. I'm sorry, I might cough. Our whole family is working on getting over from pneumonia. So I apologize for that. But it is nice to know that there's still the option for doing ctDNA in a patient that perhaps, doesn't have enough tumor tissue to be able to, make an assay themselves. I think that's one thing that is not well known. So okay, we get one of the two assays. How is it measured? Is it a quantitative number? Is it something that is positive, negative? Like how will the results come out?
Yeah, so typically it can be both qualitative, right? Just in reference to some of the results we get, whether it's, digital droplet, which typically in-house at most cancer centers, or these commercially available assays. So usually you'll get this qualitative assessment, detected, not detected, right? Positive, it was found, negative, not found. But most of the assays, I think, also quantify, right? Give you this quantitative assessment as well, which can be kind of in different formats depending on the assay. It could be something like mutant copies, right, of ctDNA per milliliters of plasma, or this mutant allele fraction, variant allele frequency. So there's a few different ways, right, that the numbers can be represented, but the important thing is the same assessment is done every time. So in patients who get these serial samples, right, over time, it's nice to be able to see not just detected, not detected, but this more, an actual number that you may see, going up or going down.
So that kind of segues us really well into my next question, which is like, how can we utilize the ctDNA in a melanoma setting? Like, what kinds of things can we do with this?
Yeah, so I think there's some really interesting applications that I think ctDNA has been looked at in studies so far. But again, I will caution that in melanoma, at least, ctDNA has not been clinically validated yet. So I think that is important, where we don't yet have data for its utility in prospective clinical trials, right? Where we can actually, a study where we use the result to make a treatment decision. So that's really key. But what we have seen from some really nice published data is the use of ctDNA in various settings. So a lot of the work, for example, has been in the adjuvant or post-surgery setting, right? So for our patients, stage 2, 3, sometimes even stage 4 melanoma, right, undergoing upfront surgery, and oftentimes patients now receiving adjuvant, right, post-surgery the drug treatments like immunotherapy. And then for monitoring, right, we assume the patient has no evidence of disease post-surgery, and typically in melanoma, we get scans, CT, PET CT, which we can only do about usually every few months, right? So there's been some studies looking at getting, for example, a post-surgery baseline ctDNA, right, and then looking at how they may correlate with relapse-free survival, right? The likelihood of the patient's melanoma relapsing afterwards. And those have shown some of the data that it could be somewhere, 15, 20% or so of patients may have detectable circulating tumor DNA in that single, post-surgery time point. So not a lot, right? Because these are patients who just had surgery. But if it is detected, those patients from various studies have been shown to have a higher risk of their melanoma relapsing, right? It could be what we've seen, though, I think that's maybe more informative than a single post-surgery time point, is actually serial monitoring, right? So from, some of our research and other groups, I think what we've seen is, if once you start your, post-surgery, let's say immunotherapy, right, anti-PD-1, nivolumab, pembrolizumab, and then we follow what's happening to the ctDNA levels, I think the dynamics of whether those levels are going up or down in that first 4 to 6 weeks, right, after starting post-surgery adjuvant treatment may actually be even more informative than that single post-surgery time point, right? From our experience, it looks like it's actually more sensitive for eventual relapse or lack of relapse than just a single post-surgery time point. So essentially in that post-surgery setting, it may have a role in possibly, maybe detecting minimal residual disease, right? Perhaps detecting, impending melanoma relapse, right? To where you could see clinically or radiographically, maybe in advance, right? And the lead times there, with the current assays, it's been a few months. So it also tells you there's a lot of room for improvement there.
Yeah, for sure. I know in our specific clinic, we use this a lot with immunotherapy in a metastatic setting to kind of try to help us determine if there's maybe some pseudo progression. And we have had anecdotally some cases where we had thought, a patient maybe was progressing, their ctDNA number, their serial number actually was trending down. And then on the next scan, we started to see shrinkage of tumor. So we've utilized ctDNA quite a bit, in that setting as well, at least.
Yeah, I would say, yeah, definitely. There's also been some studies looking at patients with metastatic melanoma. So there, the baseline likelihood of ctDNA detection tends to be much higher. I think from our experience, it's been above 90%, right? Since these are patients, with unresectable and metastatic tumors. And like you said, the dynamics of ctDNA, right, after, let's say, starting first line immunotherapies, typically within the first 4 to 6 weeks, right, before you would do your first scans, which may be as far out as 12 weeks, if we're seeing a decline in ctDNA levels, that's typically correlating with, benefit, tumor response versus increasing levels, typically with impending progression. And then really interestingly, as you said, with pseudo progression, there's actually been a couple studies looking at that as well, where it may help to differentiate, right? Where if it's a true progression, you're actually seeing rising ctDNA levels in the patient's plasma compared to their pretreatment baseline versus pseudo progression, you may actually be seeing decreasing or undetectable levels.
So I guess, you touched on this, in that you said, this isn't part of our, current, it's not validated in a clinical trial setting prospectively. Um, is ctDNA part of like current treatment guidelines when you're looking at, you know, insurance verification and things like that? I guess that's a super important aspect to kind of have around your mind.
Yeah, that's a key question. So I guess we can think of it as kind of two separate questions. So with regards to um, the insurance specific question, right? So if a physician orders it, will it insurance cover it? They may or may not,
Yeah.
right? Now, some companies, of course, because they have an interest in, they want physicians to use them, may say, oh, well, we're not going to bill it, even if your insurance doesn't cover it. But obviously, that likely won't continue
Yeah.
forever. So I think insurance is kind of hit or miss, right? And you did bring up an important point as well, the financial impact, right? These tend to be, especially these newer generation assays with this, next generation sequencing of tumor specimens are quite expensive,
Sure.
right? And it's not a guarantee that insurance may cover the cost, especially if you keep getting serial samples, right? Which I think is where you can be really informative. And I think one of the reasons is it's not yet in melanoma guidelines, right? Not yet, in NCCN guidelines, right? National Comprehensive Cancer Network, for example. There's just a general mention of, the circulating tumor markers and melanoma need to be validated in prospective clinical trials, and therefore, right, it's not included in guidelines. It's similar, ASCO, ESMO, right? They're not there yet. So I think, you know, what we do need, I think, and that's the part that's missing is these prospective clinical trials. So I feel like I can give one example, in a different tumor type that I think is very informative. So there is a really interesting trial published, I think just a couple of years ago in the New England Journal of Medicine, so a really important journal. And this was a prospective clinical trial in patients with stage 2 colon cancer.
Okay.
And so typically those patients, and I'm by no means a colon cancer expert, but typically the standard of care for surgically resected stage 2 colon cancer is to consider post-surgery or adjuvant chemotherapy. And typically there's these certain clinical pathologic risk factors that guide which patients should get this adjuvant chemo or not. So in this clinical trial, what was done is it was randomized 300 patients, 150 had the standard chemotherapy, meaning whether they got chemo or not, depended on the pathologic factors of the tumor. The other 150 patients actually got ctDNA guided chemotherapy, meaning whether or not they got post-surgery chemo depended on these two post-surgery ctDNA levels that were drawn And if both the levels were undetectable,
Okay.
chemotherapy was not given. So this was what we call a non-inferiority study. So what the investigators saw is in the group of patients who got the standard arm, about 30% of patients ended up getting chemo. In the ctDNA guided arm, only 15% ended up getting chemotherapy. So you actually spared half the patients the toxicity, as you can imagine, of chemotherapy drugs. And the critical part is their outcomes were no different,
Oh,
right?
nice.
2 years of follow-up, relapse-free survival was virtually identical, about 90% in both arms. And in the ctDNA guided arm, only half the patients needed chemotherapy, right? So it kind of tells us, right, could you use these assays, right, to de-escalate treatment, right, in the adjuvant setting, perhaps, and neoadjuvant now, right, pre-surgery treatment to maybe spare some patients, right, unnecessary treatment they might not need, or conversely, escalation studies, right? Maybe escalate if a treatment's not working, you have an early sign, maybe to go to a stronger treatment or a combination treatment or to make a change.
So I mean, you've already kind of hit on kind of the last point that I really want to cover is, what future uses do we see ctDNA having in a melanoma setting? And I mean, you've already kind of talked about it, avoiding toxicity in patients that may not need adjuvant therapy ultimately. Um, are there currently clinical trials that are being either performed or in development to kind of test these areas?
Yeah, that's a really good question. So there is a handful, I would say, in the melanoma field, research field. We may be a little bit behind some other solid tumors like colon cancer and some others where there, admittedly has been more work done. So, for example, from the United Kingdom, there is what they call the detection trial, where it's actually somewhat similar to the one I just described, an attempt to de-escalate adjuvant immunotherapy, using ctDNA in patients who may not need this. I think, they're currently in the process of, redesigning some factors in that study. There's been some looking at using in the metastatic setting ctDNA to make treatment switches or escalating treatment. We have one of those studies at Moffitt as well at my institution. But I do think what is important is, I think, increasing the sensitivity of the currently available assays, right? And I think that's been a challenge thus far is, this specificity is high, right? Almost 100%. But the sensitivity, right? There's patients where the ctDNA levels are negative, but then they still go on to have,
Mhm.
melanoma relapse, right? Where the current assays aren't quite sensitive enough to maybe pick up a small in-transit met or a small, oligometastatic lesion, right? So I think there's now kind of next, right? The next generation of the tumor-informed assays that I think are really, they call themselves ultra sensitive, right? Where they're like detecting down to like 1 parts per million from like the current 1 parts per 10,000 in terms of sensitivity. So it's kind of
Yeah,
exciting to see,
it is
right, where
exciting.
the field goes.
We definitely too have seen a little bit of difficulty with patients that may not have visceral metastases, but have like solitary brain metastases. We've had a lot of negative assays, but then, having a patient develop a CNS metastasis. So I mean, there's definitely some room for improvement in those areas as well. Um,
Yeah, and you brought up a really good point too, brain CNS metastasis, exactly. So there's been even studies looking at that and exactly, I think plasma, right, blood ctDNA, thus far, the currently available assays don't seem to be sensitive enough to pick up, let's say, a brain-only progression of melanoma, right? That's not systemic, absolutely.
So I think I wanted to end with, how are we going to use ctDNA currently? Why would we do this in a patient setting? So, I have a patient in my clinic and I say, well, we're going to get a ctDNA assay on you, but we're also going to do CT scans and MRI, depending on the patient, obviously. Um, you know, and a patient will say, well, if you're doing the ctDNA and it's so specific to my tumor, why do you need to do scans still? So I don't know if you wanted to take the opportunity to speak to that.
Yeah, no, it's a really good question. So right now, because we still lack these clinically validated, right, this prospective clinical trial data, our gold standard does still remain, right, the radiographic or clinical, progression, right? So if we see, let's say in a patient we're monitoring, in the post-surgery setting, a rising ctDNA, but let's say they were getting adjuvant immunotherapy, and then their CT scans look completely normal. What does that mean? Right?
Right.
What do we, obviously we keep following and we maybe become hypervigilant, but are we making a change? Are we escalating treatment? Right? That's the part that the missing part, right? Where I think it can be informative to collect, this information, and especially we have patients that ask for it as well. But sometimes you have the result, and then what do you do with it? Or sometimes the current assays, maybe the ones that aren't quite sensitive, sometimes they'll fluctuate slightly. They'll be
Mhm.
zero, and then next time like 0.1, and then back to
Yeah,
zero, and you're like, well, what does that mean, right? Well, probably
probably.
pointing to the
Yeah.
test needs to be more sensitive, right? And then sometimes the patients understandably get stressed. They're like, well, wait, it was negative, but now there's something, but then it's back to negative. What's happening here, right? So I think, so definitely, I think in patients where we order ctDNA assays, we do have that kind of conversation of, okay, if we're going to get this, ultimately we are still, going with your scans and clinical exams, right? Currently, at least for our major treatment decisions.
Sure. That's what we always say. This is just another layer of monitoring. It's just an extra little bit that we can do. Um, so I wanted to take a couple of minutes just to kind of cover some of these questions. I won't keep you too much longer, but one of the anonymous questions was, how many years out do you think we are from having this tool validated so it becomes more widely used?
Yeah, it's a really good question. I wish I had the exact answer,
Yeah.
but my guess is it's going to be a few more years, right?
Yeah.
Because one of the questions, because the technology also evolves, let's say you have an ongoing study that reports out, and then a year later, now a more sensitive assay comes out, and you say, well, okay, let's say the study wasn't successful. Is it because of the assay? Was it, so even in colon cancer, right, that had that nice New England Journal publication I discussed, their guidelines are still like, no, we'd like to see more data, right? And there they actually had a prospective clinical trial, and they're still a little bit cautious. So I would say it may be a few years.
Yeah. So we had another question that said, are the ctDNA different for different cancers? That yes, they are a little bit different because they test for different mutations, correct? Or specific to the tumor. Um, and she just said, how is this differentiated? Why is this currently available only for melanoma? It definitely isn't available only for melanoma. This is available in many of the solid tumors, at least from my understanding. Um,
Yeah, exactly. It's actually a lot in hematologic cancers as well, where but I would say, for the tumor-informed assays, right, the actual mutations that are being followed, right, not just for patients with different tumor types, melanoma, lung cancer, colon, but then for patients with the same tumor type can differ, right?
right.
So the tumor-informed ones are more personalized, customized to the mutations found in your cancer.
Roy asks, there seems to be so many companies with assays for ctDNA. He names a few: Natera, Castle, Exact Sciences, etc. Are they all equally sensitive? And I mean, you can't really compare them to one another because they've never been tested against one another, correct? I mean, they publish
Yeah.
data, but
So so some of the companies, yeah, they're not particularly enthusiastic about putting
right.
their assay. Um, uh, so some of the other companies, not listed there, have some newer, what they call ultra sensitive assays that they
Mm,
have compared uh, to some of the ones listed there, and have said, well, here, our assay is 100 times more sensitive, right? Ours goes from, detection of 0.01% to 0.00, or they keep adding, right? Zeros percent. So, um, And they have shown, right, with some of this newer technology where they reduce background noise, they look at like hundreds of mutations as opposed to just 16, for example, right, with the Signatera one, have said, well, I think we're increasing the level of sensitivity. But of course, missing part is the clinical validation. So then how does that change, right? Does that mean we're able to pick up a relapse earlier? Does that increase our lead time, right? So I think as months, years, right, go by, we are going to see more and more of some of these comparisons as well. And then some of those companies are also working internally on improving their current assays, and they're like, oh, we have a new one coming out, right? That's going to be better than our current one.
Yeah. And we had a question from Facebook that basically was, um, you know, patients are getting ctDNA results, but they don't know what to do with the information. And so they, are thinking that, their disease is or isn't coming back. And then they have scans that maybe differ from that information. So I think one of the things that, needs to, if you haven't already gathered that from this webinar, is that, this is still very early. We can't validate the results currently. It's still, you still need to do scans and close monitoring and clinical exams and all of the conventional therapy following modalities that we've been using so far. There was also one more, let me see, I have to screen these questions because sometimes they ask very specific things that are not HIPAA compliant. So let me look real quick. John asks, how does the cost of this ctDNA compare to a PET scan? I mean, a PET scan is obviously several $1,000s.
That's a really good question. Yeah, so PET CTs, CT scans a little bit less expensive, CT with ida and contrast, but PET CT, yeah, typically several thousands of dollars. So, but ctDNA, so I think it comes down to the frequency of it, right? So a baseline ctDNA analysis, right? If you're factoring in the cost of doing exome sequencing on the tumor sample, which is typically called whole exome sequencing, that usually is, it can be at least like couple $1,000. And then the cost of then running, right? Then you get your customized assay. So talking about the tumor-informed ones, then running that on all of your serial plasma samples may be a few $100s per sample, right? And of course, companies will have different cost schemes. But but the potential with ctDNA is you could check it more frequently, right? So maybe you check it every month, right? Whereas your PET CT maybe every few months. So, in a year, in a couple of years, right, the costs may be not too dissimilar from each other, right? Because of with ctDNA, even though each time point may be less expensive after the
Or
initial sequencing than a PET CT, you are checking it, right, in most cases more frequently than you may be getting a PET CT scan.
that makes sense. So, I mean, one example that was asked here is, a patient had melanoma removed 7 years ago. No further treatment was necessary. There's been no reoccurrence. In this early kind of stage where there was no lymph node involvement, would this even be a place where you would utilize ctDNA?
So in a patient with a very early stage
Like say a stage
melanoma,
1A melanoma.
yeah. So it may not be very informative. So the expectation is going to be negative, and that if you keep serially checking it, given the sensitivity of the current assays, it will likely just remain negative. And then let's say it becomes all of a sudden detectable, but then again, if you don't have that radiographic or clinical evidence of recurrence on an imaging, what do you do, right? What
Right.
do you do with that positive result, right? So, and that's where things like that lead time becomes important, right? Let's say it becomes positive and you're like, aha, the ctDNA is elevated, danger. But then, you also have a CT scan, you did it at the same time, and you're already seeing evidence of clinical relapse. So then what did the assay gain you, right? In that case, there was no lead time, right? With some tumors, with some assays, they're reporting these expanded lead times. Oh, 6 months in advance, right? We can detect it in the blood, a year in advance, right? So I think as we start to get to maybe data from some of these ultra sensitive assays, that may be more useful, right? For that really early uh, detection in earlier stage tumors.
Sure. We're going to take one last question. So I guess a patient had data, like some mutations identified on another company, and that company, say, went out of business. And they're asking, is that information that can be shared for future monitoring with a different company? And I feel like the answer to that is no. I think it would have to be rerun. I don't know what your opinion is. It just kind of seems like,
I would say for the commercially available, right, these CLIA validated, what we call assays that where you can actually, run on them on patient samples and report out results that have been internally validated by the company. I don't think they would be able to use sequencing data from a different company because they probably have some different methods and standards that they use. So I think they
right.
would say, if it's tumor informed, they would say, we need our own sample of the tumor tissues to be sent, and we're going to do our own. Now, the tumor naive, where you don't need, a tumor sample, then those companies have this predetermined set of panel mutations, and then they could just run it on blood alone.
Yeah. So I mean, we've learned a ton of things. I definitely think we could spend another hour fielding questions. They keep trickling in, but I think, at this point, we need to unfortunately end this webinar, but, please feel free if you do have questions. This webinar was recorded. You can watch it back and see if maybe you missed the answer to one of your questions. If you do have additional questions, you can always reach out to the Ask an Expert line through AIM, and I can either answer the question myself or I can get Dr. Aralou to do that for us. But I appreciate your expertise and your time and your help, and with such great explanations to all of the questions that we had tonight. Dr. Aralou, I hope you will come back and spend some more time with us in the future.
Yeah, I would love to. Absolutely.
That sounds amazing. Well, thanks everybody for watching, and we'll see you next time. Bye.